So I sat down today and I thought, what are the most important 3 things you need to know before EMT school? What can give you a leg up when you get into school? And what are you going to know to pass your national registry exams? Now, the first thing we're going to talk about here, as we know, emergency medical services, EMS, one of our biggest things that we learn is how to treat a patient in cardiac arrest. So we're going to go over BLS cardiac arrest here. This is the chain of survival. So what you're looking at right here are the steps that the patient will go through on the road to recovering, if they recover, from a cardiac arrest. So now I'm going to read this here. This chain can improve survival and recovery in patients with cardiac arrest. It looks simple, but there's a lot of info here. So let me explain. First, we have the activation of the emergency response. So what this means, so I want you to picture this. You're out, we're walking through the mall, or we're walking out in the city street. All of a sudden, we see a man or we see a woman, they drop and they go to cardiac arrest. Well, the first thing is this. How do we know that this patient didn't just faint? Like someone could faint and pass out, or they can go into cardiac arrest. What's the difference? Here's the difference. Fainting in medicine is called a syncope. A syncope, I'll put it on the screen here. Syncope, that's fainting or passing out. That is different than someone going into cardiac arrest. When you go into cardiac arrest, folks, I'm put on the screen here, you have no pulse. You are not breathing. So no breathing, no pulse, you're in cardiac arrest. In cardiac arrest, your heart stops beating and you stop breathing, right? If our heart stops beating, blood and oxygen can't go around our body, and we can't get oxygen in if we're not breathing, okay? So cardiac arrest means your heart has stopped. That means you're right now clinically dead. Now, we're going to get into how do we do all this, what are the steps, but these are the main broad steps. Activation of emergency response. You see that person drop, boom. You'd go up, hey, are you okay, are you okay? They're unresponsive. The cardiac arrest patient is also unresponsive. No pulse, no breathing, unresponsive, they're in cardiac arrest. What's the first thing we do as a bystander? Call 911. And then if we're trained, now we got to take action. We're going to go over that on the next few slides. So hang with me. Is high quality CPR. Now CPR itself is the chest compressions, okay? Using right here this part of the hand to provide chest compressions, okay? This is high quality CPR. The emphasis is, you may have seen mouth to mouth on TV shows. Not as important. Here's why. We're going to go over, actually, hang with me on that. I'm going to go over that on the next slide. So let's save that one, okay? Save that little information. I want to explain a little more in the next one. But for now, we'll move on. The next thing we want to do, let's say you're doing compressions. You want to call out to someone else, if you're with somebody, call out to get an AED. An AED. This is called defibrillation. Depending on the heart rhythm the patient's in. Okay, here's the deal. Quick tip. If someone's in cardiac arrest, there's only 4 heart rhythms they can be in, okay? We have, and I'll put them on the screen here. Ventricular tachycardia. That's shockable. Put a little shock next to that. Ventricular fibrillation. That's shockable. Put a little shock symbol next to that. Asystole. No shock. Okay? Pulseless electrical activity, also called PEA. No shock. So if they're in those 2 rhythms that are shockable, we can shock, and that helps improve survival and recovery. Now, advanced resus, that is done at the paramedic level, okay? Post-cardiac arrest care is when they get a pulse back, okay? And recovery would be in the hospital. Now, what's the most important chain on this? Right here. When we see somebody drop, going up, hey, are you okay, okay? They're unresponsive, no pulse, not breathing, turn them around, start compressions, call 911, get an AD. That's what saves lives. If that doesn't happen, the patient just drops, look what happens. Watch this. Here's why it's so important. Folks, time is critical. Time is critical. Here's why. In 4 to 6 minutes, patient drops, unresponsive, not breathing, no pulse, they're in cardiac arrest. Clinical death is 4 to 6 minutes. During this time, if we get the patient back, there's no irreversible damage to the brain. Okay, there may be some damage, but no irreversible damage to the brain, most likely in 4 or 6 minutes. It's clinical death. Well, they're dead right now. But let's say we were to restart their heart. They wake back up. You may have seen again on TV shows, someone's unresponsive and they're laying back and they shock them and they wake up, right? That's an example of this here. Why? Why is that? Well, here's why. Folks, for about, if we can see here, about 6 or so minutes, you could call it 6 to 10 minutes if you want to. I would call it about 4 to 6 minutes. You still, even though the patient is not breathing and the patient does not have a beating heart, blood and oxygen is still circulating around the body. I mean, like the tissues, they can hang out for a few minutes. They're not going to just die. But after 4 or 6 minutes of not getting any oxygen, well, they're gonna have damage, right? Okay. So at 6 to 10 minutes, we have biological death. Now cells start to die, so we get brain damage is likely to occur. Now here's the deal. After 10 minutes, brain damage is irreversible, except in special cases like cold water drowning and hypothermia. Time is critical. That's why I'm saying it's so important. And we learn in BLS class, we see somebody drop, oh, hey, you okay? Oh, unresponsive, no pulse, not breathing. Call, you can call 911, put it on speaker while you're working the patient up, right? Or you call 911, you get an AED because I'm trained and I'm doing compressions, right? Both are okay, right? In a real life scenario, okay? But again, shot for help, you call 911, you get an AED, and I'm going to start care would probably be the most ideal. But again, if you're by yourself, put that phone on speaker, call 911, and start compressions, right? Cool. Okay? Compressions are number one most important thing you could do besides calling 911, okay? Now, if you're watching this, you're an EMT. So now you're going to be the 911 coming to the call, right? You hope that this trained bystander, this EMT that's off duty, or this nurse or doctor that's off duty or paramedic, is there treating the patient. So again, the first thing we do, even as EMTs we got on scene, is we have to check what's going on. So we check responsiveness, tap and shout, are you okay? We see they're unresponsive. We see they have no pulse. We see they're not breathing. Yeah, they're definitely in cardiac arrest, right? Shout for nearby help and activate the emergency response. Again, this is if off duty, right? Shout for nearby help, call 911, get an AED. We've hammered that down. We got that. Okay, now, here are the steps for checking for breathing and pulse. So perform a pulse check and breathing check at the same time within 10 seconds to minimize delaying CPR. Folks, if you're questioning, do I feel a pulse? I don't know. It's probably not there, right? Right? It's probably not there. Okay. Now, other things we can do at the same time: scan the chest for rise and fall. When we breathe, our chest will move in and out. So if we're not breathing, well, we got to check for rise and fall. Check for absent or abnormal breathing for at least 5 seconds. Again, no more than 10 seconds. And palpate for a pulse. Okay? Palpate for a pulse for at least 5 seconds, but no more than 10. Now, if there's no pulse and they're not breathing, again, don't second guess yourself. You just saw them drop, right? Or someone else told you as an EMT, they weren't unresponsive, they were fine talking, they fell over. I feel no pulse, they're not breathing. Start CPR, which has compressions. If they have a pulse, what does that mean? Well, if let's say we check, they got a pulse. If they have a pulse, could be here, could be here, could be here, right? They have a pulse, but they're not responding. They're unresponsive. So the question then becomes, well, are they breathing? And how well are they breathing? So if they got a pulse, but they're not breathing or not breathing well, start ventilations at 1 breath every 6 seconds. Our goal, we want to get about 10 to 12 breaths a minute. Again, every 6 seconds, you times that, we have right where we want to be, right? Check pulse every 2 minutes, right? The goal would be about 10 to 12 breaths a minute is kind of our goal. So 1 breath every 5, 6 seconds is good. Check pulse every 2 minutes. And we're doing consistent CPR, and there's no need to stop. All this best science says, keep going with your compressions, okay? So when in doubt, remember this. What do? Keep doing compressions. Don't worry about ventilations when you're a bystander. Make sense? Okay, beautiful work. Here is the holy grail of EMS for BLS. If you know this, you'll pass BLS class and you'll pass NREMT. If you don't know this, you're gonna fail. It's simple as that. Chest compressions are gonna be compresses the chest hard and fast. We place the heel of the hand on the lower half of the sternum with the heel of the other hand, overlap on top, right? This is so important. Write this down, folks. 2 to 2.4 inches is your adult depth, how deep you're going to provide compressions. 100 to 120 compressions a minute. The ratio is 30 to 2, okay? When there's no advanced airway in place, we do 30 compressions followed by 2 breaths, okay? We have an advanced airway from a paramedic and they put a special airway in place. We do continuous compressions with 1 breath every 6 seconds, okay? Now that can be a pro of getting an advanced airway. We can just actually do what we need to do, which is continuous compressions. Okay, again, remember, you're watching as a bystander, just do continuous compressions. Allow the chest to completely recoil after each compression. So as you go up and down, switch compressor, this is key, every 2 minutes. If you're alone, you gotta do what you gotta do. But if you have a bystander, or you have obviously partners as the EMT, switch off. It should take no more than 5 seconds. So here's the deal. If I'm doing compressions and I'm standing right now with a camera angle, but if I'd be on the, next to the patient. If I'm doing compressions, right? Okay, we're gonna switch. 3, 2, 1. My other partner can be literally right next to me here or whatever. And the hands, get your hands ready. You can hover over the patient. And as soon as they let go, boom, we're right in the chest. That's what we wanna do, okay? So this is very important to science. Even for a moment, you stop compressions, that pressure goes down. So make sure that those interruptions, they should be no less than 2 seconds. I mean, 1 Mississippi, 2 Mississippi. If your hands are right there, boom, they're right in the chest. That's what we want, okay? So minimize interruptions and compressions to 10 seconds or less. I would say try to make, again, under 5 seconds. It's that important with the science. And avoid squeezing the bag and ventilating the patient like this. It's 1 breath every 6 seconds. So when in doubt, better to be a little slow than too quick, okay? Fair. Defibrillation. We already talked about this, but I just want to go over this. When the pulse is not present, we check for a shockable rhythm with the AED. Obviously, we can also do that with the life pack, right, if we're in the ambulance. Now, we're going to provide shocks when indicated. Remember, folks, ventricular tachycardia, ventricular fibrillation, shockable. Asystole and PEA are not shockable. The AED will be reading the patient's EKG to say shock or not, and you'll follow the steps, okay? You immediately resume CPR following each shock, right? We don't touch the patient when we're shocking them, but what we can do is this, okay? Same deal. So the AEDs say, okay, shock advised, do. Okay, we're gonna press the button, shock now. Hit shock, we hit shock, okay? You should be doing CPR all the way up until it says do, shock now. Okay, 3, 2, 1, and we're gonna shock. Everybody clear? Shock and back on. See? Was that less than 5 seconds? Yes, that's the biggest key to remember. Don't be hanging out, listening for the AED. What is he saying? Do compressions all the way up until that moment, man, a second or two before you shock. Then we're all clear. Okay? This is key. Again, start with chest compressions are the most important thing in the science that get fuel back. Now, that was our first lesson of the day. Okay? I got 3 lessons for you, because remember, this is about 3 different things. So if you are loving this video, if you are absolutely loving this content, I want you to smack, I want you to annihilate, pulverize that like button, and hit subscribe. There is no other channel on the face of YouTube that's going to give you this much content from EMS education. I'm Evan, the paramedic coach. Let's get after it. And we're going to now talk about pediatric assessment triangle. Now, before we go on, the first link in the description, folks, is lifetime access to my National Registry NREMT prep course. If you are getting ready for school, in school right now, or getting ready for National Registry, first link in the description, you can check it out after the video, but it's there. Now, pediatric assessment triangle. Let's talk about this. There are so many providers that struggle when it comes to children. So this is why I want to talk about this today. How do we assess children in the ambulance? So they've come up with this triangle whereby if I look at a child and I look at the child's appearance, their work of breathing, and their circulation, I can make a decision. Are they sick or not that sick, right? Are they critical or not critical? Are they stable or unstable? Now, remember, folks, an adult patient can explain to you perfectly fine what happened, what's going on. The younger the child, the more they cannot communicate what happened. Like they fell from a certain height or whatever traumatic event may happen or illness they have, they may not be able to communicate, especially when they're very, very young. That's why we have this. Okay, so we start. You're going to a child. Maybe you're uncomfortable. Oh man, I don't see a lot of kids. Maybe you don't have any kids of your own. This is why I love this. Look here, the initial assessment. Okay, so here's what we do. Okay, I'm going to a child, A, B, C. Appearance, work of breathing, circulation. All right, let's start with appearance. What's that mnemonic Evan said? Hit them with tickles. Use the tickles mnemonic as an adjunct. So here's what we do. We look at their tone. Write this down, folks. Look at their tone. Look at their interactiveness. Look at their consolability. Look at their look and gaze and speech and cry. If you break this down, tone meaning what's their muscle tone? Are they kind of just like flaccid and hanging out, or they have strong muscle tone? Interactiveness. Are they interacting with their parent, you, or are they kind of just aloof, looking up? Consolability. If they're unable to be consoled by the parent, that could be concerning. This is very important. The look and gaze. If a child who doesn't know you lets you basically assess whatever you need to assess, that can actually be ominous. They should be tracking your movements around the room like this. Who the hell is this guy? Who the hell is this guy, right? That's what they should be doing. Speech and cry. Do they have a loud cry, which in some situations could be good because they have an open airway and they're crying, or there's no cry at all. A very tired, non-crying baby that doesn't care that you're there is probably very sick. Does that make sense? Okay. Now, I have some pearls here, folks. If they're unresponsive, again, and we're a bystander, shout for nearby help, assess breathing and pulse, activate emergency response system. If they're crying or upset, it may be difficult to know if the child is responding appropriately. Try to keep the child calm, let them remain with their parent or caregiver if possible, which is very important, or distract them with toys. Now, we're in the ambulance here. What are we going to do? Tickles. Okay? What's their degree of inactivity, interactivity, muscle tone, and their verbal response or cry? Again, the very tired, don't care that you're here, child that's looks like they're half asleep and not crying, let's say they're an infant, that's the one that's really sick, really sick. I actually don't mind if I hear a strong cry because I know I got an airway. I know they're awake. You with me? Okay. So, worker breathing. Well, it breaks down to, well, they could be in a tripod or sniffing position. Retractions, that's pulling in between the ribs. And audible breath sounds. So then what if we do our tickles mnemonic? Let's say, okay, I got a rough idea here. Let's get some lung sounds. What's their body position in? Are they sitting back like this? Right? Sniffing position, trying to get air in. Are they in the tripod position like this? Right? What are the lung sounds? Okay. Do we see any accessory muscle use, like pulling here in the neck or retractions, pulling in between the ribs? So we look for signs of absent or increased respiratory effort. We look for abnormal breathing sounds. Wheezing. Folks, wheezing is either asthma, anaphylaxis, or COPD. If you hear a wheeze with your scope, think AAC. Stridor is an upper airway sound. Wheezing is a lower airway sound. Stridor I can hear across the room. Stridor would be like a foreign body airway. It's a partially obstructed upper airway. That's stridor, a partially obstructed upper airway. And it makes a loud sound I can hear across the room, okay? Foreign body airway obstructions could be it. It could be croup, could be epiglottitis, could be anaphylaxis, right? To name a few, okay? Could be inhalation burns, but for another video, okay? But grunting is ominous. Snoring respirations could be like a blocked airway, right? Observe the child's position, and if it suggests respiratory distress, like a tripod or sniffing position, that would be respiratory distress. They're under distress, right? So look, folks, I see a child and they're in tripod or they're like this, right? Bobbing back and forth. They're probably in distress. I see again that tired, don't care that I'm there. No look, no gaze. That's the really sick child that's probably breathing slow and in respiratory failure, okay? The stress, they may be breathing more fast and more anxious. When they get tired and don't care anymore, that's when they're about to go into arrest or unresponsive. Okay, next, circulation. Pale, mottled, or cyanotic. Essentially here, pale or bluing of the skin or nails, okay? So this is a quick list. Let's just go through it. Assess a child's skin color. So appearance, I did my tickles mnemonic. Hit them with tickles. Breathing, get lung sounds. What do I hear? What's their body position? Circulation, look at their skin. Skin tell you anything? Right? Look for obvious signs of bleeding. Exposed patient, any bleeding I need to worry about. Do I see pale skin? Do I see mottling or cyanosis? Cyanosis is very ominous. Bluing in the skin, lack of oxygen. Suggests poor perfusion, oxygenation, or both. Okay, a flushed appearance suggests fever or distributive shock like sepsis, toxins, anaphylaxis. Bruising suggests injury. We know that. Okay, if we see a purple discoloration caused by bleeding within the skin, this could be part of a life-threatening infection. Again, more advanced stuff, but again, if we see any sort of skin condition that's abnormal, that might lead us to think about a trauma or they're not getting enough oxygen. Hey, by the way, what are the two biggest things when kids get in trouble? Traumatic injuries is number 2, but number 1, respiratory. Okay, that's how we go over this. Now, I got you at number 3. You ready? The third thing that we got to know, some pearls to know, some things to know about before EMT school, or if you're getting ready for NREMT, is stroke. So, stroke, folks, is a CVA, the big term. Here it is. It's a cerebrovascular accident, is the medical term for stroke. It's a brain attack. It is the interruption of blood flow to an area of the brain resulting in loss of brain function. Okay? So ischemia is a reduction in the blood supply causing inadequate oxygen being delivered to the cells. So the cells stop functioning properly. If blood supply is restored in time, the cells will not die. So let me explain. We're going to talk about here in a moment a full-on stroke, and we're going to talk about a TIA, okay? A transient ischemic attack, okay? We're going to talk about this. So a full-blown stroke, that is one of your cerebral arteries that is being blocked. The most common being the middle cerebral artery. Now, when I have a heart attack, it's a blockage of my coronary artery, and that coronary artery supplies blood to the heart's muscle. If it's blocked, I have a heart attack. In the brain, if I have a cerebral artery that gets blocked, well, the cerebral arteries supply blood to the tissues of the brain. If I block them, cells will die in the brain. Tissue will die in the brain. Does that make sense? Okay. Ischemia means I don't have a full blockage. Maybe it's like the artery's kind of being choked, or maybe it was temporarily blocked and it came back. That's more about ischemia. Ischemia is usually more like a partial blockage, like it's a reduction of blood flow to the brain, whereby a stroke is it's literally blocked. Like a heart attack is it's blocked. Ischemia is it's being choked. It's like partially blocked. Make sense? Okay, good. Let's continue. Now let's talk here about the modifiable risk factors of stroke. These also coincide with any sort of heart attack, circulation issues, but also to do with stroke. Now look at these risk factors. What does this mean? Folks, if your patient, someone you know, has this laundry list or some of these things on this laundry list of risk factors, they are going to be at a higher risk of getting a clot, of getting a stroke. So what it is, hypertension, okay, heart disease, atherosclerosis, okay? So do we have a buildup of plaque in the arteries, okay? Diabetes, cigarette smoking, high cholesterol levels, obesity, poor diet, AFib, atrial fibrillation, it's an EKG, okay? It is a heart condition. Now this is big. Hypercoagulable states, okay? Hypercoagulable states like polycythemia or birth control use, okay? Also bed rest, okay? Or recent surgery. Peripheral artery disease and sickle cell disease. Now I put all of them down here, okay? Some of these are more modifiable than others, okay? But this is what we're looking at here of the risk factors on how someone ends up getting a stroke. Now, here are the types of stroke, okay? We have ischemic strokes at the blood clot in one of your cerebral arteries. So your brain is going to start to, your cells are going to have to die, right? Blood clot. A hemorrhagic stroke, that's actually bleeding in the brain. So what can happen, folks, is we can have an artery through high blood pressure and boom, it bursts. That's a hemorrhagic stroke. So that can be an artery that's under stress, it gets weak, it bulges and bursts. It's hemorrhagic. That's bleeding like all over the brain, okay? A transient ischemic attack is a mini stroke, like I said, like the artery is being choked, and it resolves itself at some point, okay? Hang with me. Now, let's first talk about the ischemic stroke. The blood clot inhibits the blood supply from getting to a part of the brain. The most common type of stroke, 87%, that's well over 2/3, it's like closer to 3/4, are an ischemic stroke. Okay, they're formed by a thrombosis. A blood clot formed at the site of the blockage in the brain is most common. An embolus is where a blood clot forms somewhere else in another area, breaks off, and travels to the site to get blocked in the brain. So either by a thrombus, which is a blood clot in the site of the brain, or an embolus, I get a blood clot somewhere else in my body, it breaks off, and then lodges through my system in my brain, okay? This is the most common type of stroke, an ischemic stroke, where the blood clot inhibits the blood supply getting to a part of the brain. The artery is literally blocked. One of your cerebral arteries is literally blocked, and the middle cerebral artery is usually the artery that's blocked. And this is why we have, and I'll show you in a little bit, it's called the B-FAST scale, because most middle cerebral artery strokes look like the B-FAST scale in their signs and symptoms. Okay, here we go. Hemorrhagic is bleeding inside the brain. A vessel burst, and now think about it. Well, blood's normally going through the vessel, but in this case, the vessel's bursted, so blood's like going all over my brain, inside my head, right? It's bleeding inside the brain. A blood vessel ruptures inside the brain. That's I had the worst headache of my life, boom, okay? It's accumulated blood that compresses vessels in the brain and decreases perfusion of oxygenated blood to the area, and brain cells begin to die, ischemia. It's only about 13% of strokes. Again, we talk about a really bad headache out of nowhere, we watch for this, like a pop in your head, that's this. They're often massive strokes because there's so much pressure going into the brain that you bleed out, okay? And they have a high fatality rate. This is sinister. This is very sinister. A transient ischemic attack is a TIA. These are stroke-like symptoms that resolve within 24 hours. I'm gonna say it again. A TIA is a stroke-like symptoms that resolve within 24 hours. So yeah, that's the big key of a TIA. They eventually resolve. A TIA must resolve. It's a mini stroke. So think of a TIA like angina for the heart. What are we talking about? It's a partial obstruction. Oh, I got pain. Ooh, I had stroke symptoms, right? Ooh, I had stroke symptoms, right? But it resolved and I'm okay. But I'm at greater risk now of having the real heart attack in this case, or a real stroke in this case. Make sense? So think of a TIA like angina. It's a warning sign that something worse may occur if not treated. Angina will lead to a heart attack one day. A TIA will lead to an actual stroke, which is the actual MI, myocardial infarction. A heart attack is a life threat. A stroke is a life threat. This is an emergency, but it resolves, so it won't be a life threat. Make sense? Okay. Blood flow is obstructed to the brain, and stroke-like symptoms occur. In EMS, we're not going to know. We're going to do a B-FAST scale, and it's going to be positive for stroke. Take them to the hospital, and they go, oh, it's a TIA. Okay? There's no actual brain tissue death, okay? But it's impossible to differentiate a TIA and a stroke in the first 24 hours, okay? A TIA is a medical emergency. Most patients recover well, but it's a warning sign that a more severe stroke can occur in the future. And folks, listen to this stat. 1/3 of patients who have a TIA will experience a stroke within a year. Folks, did you hear that? Write that down. 1/3 of all these patients that have TIA are going to have a stroke within 12 months. That should blow your mind. Okay? All right, a little dark humor there. Okay, all right, let's continue. Now, here are our signs and symptoms. Okay, now this is all of them with the medical terms attached to them, okay? So I got a really cool slide coming up, so hang with me, okay? And by the way, like this video, annihilate that like button, make sure you're subscribed if you're not, if you're enjoying this, okay? This is stuff you gotta know for EMT school, NREMT. If you wanna pass, we gotta know this. So watch this video over 1, 2, 3, 4 times till you get it down cold, okay? Now, what we're talking about here is weakness or numbness on one side of the body. Could be the legs, could be the arms. Facial droop, okay? Talking about paralysis to one side of the body, numbness one side of the body, left or right. Facial droop, loss of muscle coordination or balance, ataxia, vision loss in the same field of both eyes, double vision, difficulty swallowing, difficulty expressing or understanding speech, slurred speech. Listen, folks, this is important. This is a test question. Listen up. The hemisphere of the brain affected by the stroke exhibits symptoms on the contralateral side of the body. That's what this means, folks. If I'm having a stroke to the left side, this is my left hand, the left side of my brain, I'm going to experience right side weakness, right side paralysis, right sided numbness. If I'm having a stroke to the right side of my brain, this is my right hand, then I'm going to have experiencing weakness, numbness on the left side of my body. Does that make sense? Okay, good. Now, other common signs and symptoms. We talked about it. WAP, sudden severe headache, sudden confusion, dizziness, combativeness, altered mental status, seizures, convulsions, incontinence, and coma. And folks, here we go. Let's hit it home. The middle cerebral artery, the MCA, primarily exhibits symptoms in the upper extremities, whereas the anterior cerebral artery, the ACA, exhibits symptoms primarily in the lower extremities when a stroke occurs. Is that a tip? Is that a quick tip for you? So most MCA strokes are going to be upper body. Most in the lower body symptoms are of a anterior cerebral artery stroke. They're both bad. Just want to give you something cool. I thought it was pretty interesting. Okay. Now, here's the big slide I want to show you. Here it is. This is what we do. We go to a patient. We think they're having a stroke. They're altered mental status. They're not acting right. They don't know where they are, but maybe they're awake. We do what's called a BFAST assessment. So first we check their balance. Then we check their eyes. Then we look for facial droop, a difference in their facial droop. So we're going to say, can you smile? And we're looking for if one side drops. Arm drift test. We're telling them to hold their arms out for about 10 seconds. If we have one side drops or one side they literally can't bring the arm up even at all, then that's what it's going to be. Speech. Can they speak, or is there slurred speech? And then time. When was the time they were last seen normal? When was the time they were last seen normal? So how's their balance? Okay. Eyes. Any vision loss? Do we see any nystagmus or fluttering in the eyes when they look up? Okay. Ask the patient to smile. Ask the patient to close their eyes and then hold out their arms. If we have a side drop or they literally can't get their arm up with like this, well, they have weakness, right? Speech, slurred or can't speak, and then when they last seem normal. Rapid transport to the hospital. This is your stroke care. And also make sure that we get vital signs. And also make sure we check your blood glucose level, because your patient could just be altered mental status because their blood sugar is low, not having a stroke. It can be a mimicker of a stroke. So we go to somebody with, let's say I'm two-partner group. I'm going to check a blood sugar, and my partner's going to do BFAST. And then we're going to get vital signs, right? So I can do BFAST, I can get my vitals, you're doing the blood sugar, and then we see what we got. Blood sugar is normal, BFAST is positive, and the vital signs looks they're having a stroke, maybe even some stuff like they're hypertensive, right? We talked about like pressure. Wow, looks like a stroke. We're going to call a stroke alert, rapid transfer to hospital. Folks, you will never kick yourself for not calling a stroke alert. You will kick yourself for not calling a stroke alert. So when in doubt, don't be scared to call a stroke alert, but do your assessment. Get your history of the patient. Remember the risk factors? Do they have risk factors? If we go to a patient, wow, they're 65 years old, they have diabetes, high blood pressure, high cholesterol. I see their meds. It treats high blood pressure, high cholesterol. They were fine 2 hours ago. Now the patient can't talk. Their whole right side of their body is weak. Their blood glucose is normal. It's 130. Call a stroke alert, folks. With me? Beautiful work. And folks, again, if you're getting ready for school, if you're getting ready for EMT, AMT, paramedic, first responder in class, in school, if you're somebody out there who's in right now where you're trying to pass the NREMT exam to any level, our flagship program is the first link in the description, folks. Over 60,000 EMS students have gone through this program. You get lifetime access, videos, practice questions, study guides, worksheets. It's the first link in the description. Check it out. It's a video you can watch there. And make sure you like and subscribe, and I'll see you in the next one. Let's go. Great work today.